Welcome to our edition of In Circulation. We are here today with Dr. Bart Denys, an interventional cardiologist from Cardiovascular Institute of the South. My name is Pam Pratt. I am the VP of Practice Management for Cardiovascular Logistics. Dr. Denys, thank you so much for joining us today. And we're going to be talking about intertwining the business and practice of cardiology. Dr. Denys, you've been doing this for a long time. So what have you seen in your time as a cardiologist? What do you look at in the field today on what has changed?
Great question. Pam, just to start, we grew a practice together. You know all about it. It's no secret that we spent more than 1 decade. So what I have noticed that has changed in the last decade is looking at 3 different groups. We have patients, we have support personnel, and we have providers. If I look at patients have changed. They are more knowledgeable. Unfortunately, they don't always have the right information. We joke about Dr. Google and Mr. TikTok, and unfortunately some of our colleagues, the one secret your cardiologist does not want you to know. You and I know we don't have secrets, but it's hard to translate them. When we look at support staff, the major change there has been the introduction of MID providers. But what has not changed, in my opinion, is physician practices. Mm-hmm. Physicians have always been individual in their approach to things, individual in their treatment plans. And I visited probably over 100 physician practices over a lifetime, and I always see a nice building and a nice name. And when I walk in there, I see 5 or 6 individual physician practices. Mm-hmm. And the coming together of physicians in a harmonized manner has not happened. And I think that has an effect on everything. It has an effect on quality, it has an effect on cost, and of course cost and efficiency go together. But cost efficiency also go together with quality. Mm-hmm. What has not changed in the last 20 years is our focus on where we go. The focus is still on intervention, and the focus is on volume. Whereas what we express and what we talk about is different. We talk about quality and we talk about patient-centered approach. Mm-hmm. But if you look at how the practice is run, there's not much different compared to what it was 20 years ago. Mm-hmm. Just the way patients are received. We have a nurse puts the patient in the room, measures the blood pressure, looks at the medicine list, and says the doctor will be right with you. Mm-hmm. The doctor comes in, and now the technology has changed. Instead of having writing and be able to talk and write, now the patient is looking at a physician who looks at the screen. Mm-hmm. And is either dictating, typing, or a combination of both. And then at the end of the encounter, the physician states what? Nurse will be right with you. Mm-hmm. And so nothing in that process has changed. And what needs to change to get that, first of all, get the staff involved. Mm-hmm. The staff is not just a clerical activity.
They're an extension.
They have to be an extension.
Yeah.
And I don't see that enough. Mm-hmm. I see the other, unfortunately. I have seen physicians tell a nurse who wants to talk about a patient's problem, don't try to be a doctor. Mm-hmm. And that has to change. Because my staff, even my medtechs, my LPNs, are trained to go in the room, ask patients questions. How are you doing? How's your family? What do you want to discuss with the doctor? So by the time they approach me, I have already seen a problem.
So how do you, if you're going to express to a newer physician on how to make sure that they start off with that, having their staff being an extension of them, how do they go about doing that?
They're already starting at the wrong foot. Mm-hmm. The fellowship, the training program is where? It happens in the hospital, right?
Yeah.
So the focus is again on what? Intervention and hospital medicine. Mm-hmm. And in most fellowship programs, they may have 1 clinic a month where they see 5 patients. And it's supervised and unsupervised. In essence, nobody has ever taught them to see patients, how to manage patients, or how to manage an office.
Right, because it's not just, as a physician, you're the leader, right? You're not
Right.
just the physician.
Right.
I mean, you're taking care of the patient. Obviously, that is your primary goal.
Right.
However, at the end of the day, you're really managing the business around your practice as well. So how do we
100%.
tell these younger physicians on how to do that? Because like you said, they're not learning that from school.
100%, Pam. But look at what happens when that young physician comes into an established practice. He doesn't know. He's insecure, and he
Yeah.
wants to adhere to what the practice is. So he has some senior members telling him, we do this, we do that, we do that. And somewhere along the lines, he develops his own little style, his own little program, which magically is now going to be different from everybody else. So it has to start by a mentorship.
Ah, good point.
There's no other way.
Yeah.
Someone has to tell that physician, it's okay. It's maybe dictate outside the room. Come inside the room, be present. Talk to that patient, be knowledgeable. Ask if there's any questions. Maybe you can tell the patient, look, if you don't have any questions and everything is fine, let's go out and we'll make a new appointment. So make that one continuing without the need for having the nurse come back and forth and being them strictly a clerical. The advantages is multiple. First of all, burnout. Your staff will do 50% of your non-productive work, and you will have your energy and training focused on making the decisions for the patient. But there's so many other things involved. Oh, how much of that medicine do I take? I need a refill. I need this paper for my insurance. I need this and that. I don't want to do all of that.
Yeah, that's all stuff your staff should easily be able to do. They know the expectation, right?
And if they are trained appropriately.
Yeah.
For instance, medication management. If they are knowledgeable, they can do it. I have these little things I dictate in front of my staff. And I have one of my nurses has UpToDate open at all time.
UpToDate is?
UpToDate is an online program that gives you medical answers, looks into the literature.
Okay.
So let's say I have a patient, as an example, who has an aortic stenosis, and I want to know what are the new criteria for referring a patient for valve replacement by echo. They look it up and they will tell me right away what it is.
Oh, wow.
So now I have learned.
And they've learned.
So the irony is I can actually start asking them questions. So what's the dose of that medicine again? And they will tell me, they will help me out. So they feel like they're an integral part of it. And my patients benefit because they can answer phone calls more directly. But it's something that you are aware of, Pam. We have started off very early in our practice. But it will have to come from the new physicians because the physicians are very difficult to change.
Yeah.
They set in their ways. They have always been the leaders. They've always been the one that were in charge.
Right.
And it's incredibly difficult to change that mindset or even change their practices. Just looking at a practice with 5 cardiologists, you will find 5 different testing ordering
Right.
symptoms. You will have 5 different beta blockers, even though we could agree maybe on 1 or 2. And it's that harmonization that is the management challenge.
Yeah, so what it sounds like you've done very successfully, you've created a care team. And from working with you for many years, I know that your care team is not only your clinical staff. You've also involved your clerical staff because, I mean, obviously, you know, you've got to remember and appreciate that that's the face of your practice, right? Whether it's the schedulers or the front office team and things like that. So I know you've done a really good job with that.
Pam, you're so right. You've heard me say many times before, the most important person in my practice is the front person. Because if that person makes the patient, to put it lightly, unhappy,
Yeah.
I will carry that load and it will impact the trust they have in me and our ability to manage them appropriately.
Yeah, totally agree. And of course then, you know, being that you're building those type of care teams, your team respects you, that you're respecting them, and of course all of that just trickles down into patient satisfaction, right?
100%.
And improving quality all at the same
100%.
time. So along the same lines of, you know, talking about building practices, what have you done to be attuned to what's going on in your market? And what do you tell a physician to say, look, you need to remember, like, you've got to know your patient population, you've got to know your referring physicians, all these different things. How do you stay attuned to what's going on in the market?
Well, we still put too much focus on technology, intervention, and volume. If I look at physician advertisement, it's already reflected. Physician X, the first one to use device Y, in location Z. Has nothing to do with patient care, has nothing to do with quality. It is just a focus on intervention. And where we miss in the market is in the wellness program. I've seen practices have dabbed in it a little bit. They've tried to have a women's center, and it was nice. It was pastel colors, and we had some flowers on
Different
the corner,
furniture.
and it was all nice. But nothing changed. It was that same practice in a different environment, and many of these centers have failed because they did not address the wellness part. And where we have missed the boat is I see independent nurse practitioner practices show up with, quote, holistic care. And obviously there's money for it, but we have not caught that market. They get $3,000 worth of blood work, then they have to buy $300 worth of supplements, and you have to buy it from this practice because they quote the best. So we have cash pay. So somewhere along the line there are healthcare dollars that we're missing within the WellCare system.
Well, not just dollars. How does this benefit the patient, right? At the end of the day, we know that wellness and prevention, not only does it cost less for the payers, but in the long run, it's best for the patient, right? So you're saying when you're looking at your market, you feel like now prevention and wellness is really across the board, that is just something that patients are looking for.
100%.
Yeah.
And risk assessment, for instance, cardiology market used to be the elderly market, right? I remember when I started 30, 40 years ago, the only patient I used to see used the one that had a heart attack, or they're about to have a leg amputation, or any of these, basically patients at the end of their disease process. And I have worked very hard to catch that earlier and earlier. And fortunately, I get to see people in their 20s, but you have to have a sense of how am I assessing their risk. We have cholesterol and all these things, but we have, for instance, we can measure the thickening of the carotid ultrasound in age 25 and showing them that they're at higher risk. And we literally do prevention 20 years before their calcium score will be positive. And you have to explain it to people. For instance, I tell them measuring the carotid is like a faucet that is wet. It takes a long time before you have crud around it. The calcium score is the crud. We want to fix it when it's wet. And we have to go this way in taking care of the healthy. Because within the medical field, we're in an unfortunate situation. Everything we treat doesn't hurt.
Right.
Diabetes doesn't hurt, high blood pressure, obesity, smoking, hyperlipidemia, none of it hurts. If I was a back pain doctor, everybody wants a shot.
It hurts right here.
And everybody wants a shot. So we're making the step from as an interventional specialty to a prevention. It's going to take time, years, and effort to go to the population.
Okay.
So just a little advertising twist makes a difference. What is your risk for vascular disease? How likely are you to have a heart attack? These are things that ring into people.
Yeah.
Not like, let's go and see what your EKG shows.
Yeah.
Or any other measurement. Or a blood pressure check. Okay, blood pressure check is fine, but it has to be guided within a broader scheme.
Okay. So let's move into talking about building a practice in regards to referring physicians. I know that you were very successful when you came into your market. Not a lot of physicians knew you at the time when you first got there, and you had to do a lot of things to be able to build that. And I don't think that is something that needs to be lost today. I think it's just as important today. So how did you build that? How did you build those relationships with those referring physicians? Let's talk about that.
Well, first of all, the same thing everybody does, introduce yourself to the community. But I came with a message that for many of my primary care physicians was different. And my message was, I am a cardiologist and I only treat cardiac problems.
Yeah.
And that was refreshing to them because many of them felt that when they sent their patient to a cardiologist, they never got the patient back.
Right.
And in the beginning, I saw how that came. Patients said, well, I already have a doctor for this and I see a cardiologist, can you treat my diabetes? My answer was no. That is not my specialty and I would like your doctor to do it. Or someone came in with a cold. Hey doc, can you prescribe me an antibiotic? And it's easy to do.
Yeah.
Of course we can do it. But I made it very simple. I said, look, I haven't done this in many years. I specialize in the heart, but I will call your family doctor and see if he can work you in today. And that little thing was magical. I would say within 6 months, my referrals doubled, just because that fear of, quote, losing your patient was not under there. The second thing is you have to engage in the community. If people don't know you, they don't know you. And especially my message to younger physicians, that it seems to be something that is lost. It's a new generation. It is more of a focus on lifestyle, and outside the office it is no longer part of it, but ultimately it is. You live in a community and you live with people that you will treat. But many people live 50 miles away, 60 miles away. I chose to live in my community.
That's right.
I volunteered to talk about risk management for everybody who wanted to listen.
The fire department, I remember that, yeah.
Even the organization of 16 women that called themselves the Southern Bells. And okay,
I'll talk to them.
There's nothing lost. And even if they don't have a problem, magically, 3 years later you may see when I say, yeah, you came and talked to us. And so it is that. I happen to be hobbies that were beneficial. I worked as a car mechanic before, so instantly I became the car doctor, and I had referrals from all the dealerships and in the mechanics. Since then, I went to the police academy, became a sheriff's deputy, so I have all of law enforcement that's coming in. And just to illustrate that when you work with a community, they will greatly reward you.
Yeah.
I mean, if I'm sitting in my office, thrumming my thumb, waiting for people to come, and nobody knows me, so if they know you, they will come to my office and they say, look, I want to see Doc because, look, I went on patrol with him.
Yeah. And then the same goes, going back to the referring physicians. I know that there's got to be communication with those physicians, like you said, in the community. Nowadays, it's a little different, right? A lot of people want to do everything by text and by, social media and things like that. But I think that the art of communication, face-to-face communication or picking up a phone still needs to be practiced.
And it is increasingly more difficult because, as you said, it's all electronic. I don't talk to my physicians as often anymore. And part of it is that all these offices are not shielded off with 2 layers.
Yeah.
I have to go to 15 messages and type 10 numbers before I can get to the front desk. And then they will leave a message. Fortunately, I still have the personal cell phone numbers for most of my physicians. And if I have a question about their patients, let's say someone comes with an A1C of 11, I will call that physician and see if they can see that patient. And we do that vice versa. But it works the other way around.
Yeah.
It will be, Bart, I have a patient here with AFib, can I send them over? Absolutely. I will find a spot for that patient.
Yeah.
And that's still an advantage that we have in practice. I see that hospital-based practices are a lot tighter in their scheduling. I don't want to be in a situation where it's 3 months for a patient to get an appointment.
Well, access is key, right?
Yes.
If we want our patients to come and see us, we've got to welcome them with open arms. We got to give them the availability to be able to get in. And to your point, I think having a physician or even a patient who is having something going on, you want to just be able to just go ahead and accept them and get them in the door. So I think that's a very good strategy in growing business.
To your point, we have initiated an express clinic. We have advertised it heavily in the community, and what prompted this was the chaos at the emergency rooms.
Yeah.
Patients go to chest pain to emergency room, they were sitting there 6-7 hours, and they go home and it was not an issue. Our express clinic is aimed at ruling out acute disease.
Right.
You have chest pain, we will get you an EKG, we have a rapid troponin that we can check. We have a supervising physician. Most people will be seen by a nurse practitioner, a mid provider. But we have the ability to very rapidly triage patient. And it has been very successful. The number of patients we have seen as new patient has been high, which surprisingly, nice bonus to the program.
And listen, for a patient, if I'm having an issue today, I really want to try to get in today because I'm scared, right? I'm worried that I have something major going on.
Yeah.
So what a benefit for the patient that they can come, be seen, get their fears taken away. I mean, that's a huge, huge benefit.
And being in the community works in many ways. I had a little RV. I went to a center to repair it, talked to the gentleman, 2 years ago. A month ago, I got a phone call, Doc, I need a favor. I know it was a problem. Oh, I'm having chest pain. I said, come right over. But I have the ability to do that.
That's right.
So I'll work him in somewhere, does not matter. But the fact that we are available for a specialty that can be acute, I think is unmeasurable.
It is, definitely. Going back to your comment about your extenders being in the express clinic, and you talked about that's being something kind of newer in medicine today. Let's talk about that because I know they're an important part of your practice.
They are our mid providers. It comes down to the same thing, training. I have done some efforts in training. For instance, a simple thing, I have a course on pharmacology so that they get to know what is the difference between the different medication, what do we do. We had a course on newer treatments in heart failure with some experts on the field. Happened to be my son, who's a PhD in cardiac receptors. Of course, he's much smarter than I am. But it was an excellent opportunity to educate our nurse practitioners as what to do, have them a deeper understanding of what it is. Because what I found is most of our nurse practitioners do incredibly well in a hospital setting. Why? Because they're one-on-one supervised. But we put them in an office, and all of a sudden they have to act by themselves.
Yeah.
And there is supervision in that they can go and ask for problems or revisit a patient, and we go and take care of it. But it's not the same one-on-one interaction that they have in the hospital. So training for hospital-based, for office-based visits remains a challenge.
But in this day, when we're going back to talking about access, right, we're going to have to utilize our extenders more in order to get the patients in the door, because there's just not going to be enough of you and way more patients that need to get in. So we know that's one that we really have to focus on.
We do, and within my practice, I try to do my part. My practice is open for nurse practitioners to come one-on-one and be in clinic with me. We try to do it for all new nurse practitioners. They come through my clinic for 3 days, so they get to see not only the medicine part, but more importantly, I want to show them how my team is integrated.
Yeah.
Because I do not make a difference between LPNs, RNs, whatever they are part of my team. When we changed over to switch some LPNs to medtechs, I was the first one to take a medtech in. If I can train them, they'll be fine. And it has worked out great, and it's now something we have expanded across our organization.
How do you do all of those different things?
First of all, you have to know what's happening in cardiology, but you also have to have your pulse on the population, the patients, and the community, and see what it takes to get them to convince to do what they do.
And that helps you be successful, and that helps us be successful as well. And of course, in the end, all of that helps the patient. Always going back to the patient, right?
Pam, you're a great example, you know.
I learned from you.
Yeah.
If you were going to give one piece of advice to cardiologists leading into the next decade, you know, these newer physicians we keep talking about, how can they successfully grow their practice, what would that be?
Engage in the community, teach your staff, and walk away from the emphasis on volume and intervention. But that's definitely the goal, because even if you look back at a pure business standpoint, 30 years ago, the reimbursement for a stent was $1,500. And it made sense, and it prompted an expeditious increment in trained physicians. This day and age, it's what, on average about $300.
Yeah.
So, and that's not even taking into account inflation, etc. Reimbursement rates have not changed in 20 years. Pretty much, if anything, they have decreased. So the whole screen has changed. To my point, for the first time, I think 80 plus physicians, positions for fellows in interventional cardiology were left unfilled.
Oh, wow.
So that is 80 openings that are not filled. And people used to fight for these positions 20 years ago. The same is true for structural heart disease. These positions are no longer filled. And there's a shift in physicians as well. I mentioned my son being an MD cardiologist, PhD. He's not interested in interventions. It is lifestyle, saying he can serve patients better in the office than he can in the hospital.
Yeah.
And that the goal is to keep people out of the hospital and focus more on prevention, home care, because they ultimately, if we want to keep healthcare in a budget, we have to diminish or reduce the number of hospitalizations.
Oh, without a doubt.
Which is back on a focus on wellness versus the end product, patching it up. What we see with heart failure, okay, the efforts that we have done for measure heart rate, heart failure, and address this proactively versus people who go to the hospital, patch it up, come back, go to hospitals, and over recurrent. It's expensive, it's taxing on the office too, because these people keep coming back and keep coming back.
Good. Anything else you want to add to the conversation? I mean, this has been great, you know, talking about how we built, how we've evolved and built practices, and what are we going into in the future. I think it's been fantastic.
The biggest message overall, never accept the status quo. The moment you status quo, you freeze. you need to move forward. The world moves forward, and we as physicians ourselves, on a personal level, the way we practice, we have to move forward too.
Thank you very much for watching today. I hope you enjoyed all the information that we were able to share, and look forward to our next edition.
Good.